Thank you, everyone. My name is Johan Nunes from the Department of Politics here at York. Thank you all for your excellent presentation. I think it was a fascinating set of perspectives. Thank you also, Godfrey's still with us, right? Yeah. Thank you also, Godfrey, for joining. Thank you, Godfrey, for joining us, and I second your comments, and I hope that we can continue to collaborate in documenting public health in Zimbabwe and other places, and focusing in particular, as you mentioned, on the role of communities and community health workers. I had lots of questions, but I don't want to monopolize, so I'm just going to stick with a couple of questions. To Sue, I was very interested in something that you said at the end of your presentation about that medical association initiative that happened in 1965, if my memory serves me, and that in your view points towards what could be a successful or at least an effective way to approach these sorts of programs. So if I understood correctly, this was an initiative on the part of the Nepal Medical Association, and I would like to get some more details about this. Why did this initiative come up in 1965? Was it as a reaction as to what was perceived as the inefficiency of the pilot that was being led by WHO? Was it in conjunction with WHO efforts? How exactly did this initiative come about? And if you could give us some more details on that, that would be great. Yeah. And to Carlos, fascinating research. I think you've touched upon in your research and in this project a crucial tension and a crucial problem in the Brazilian public health system. And I would dare say a crucial issue in the future of Brazilian democracy. What you hinted at in your project, in your research, is a problem that the universal health system has gone through since its inception, the SUS, the Brazilian universal health system, which is the tension between the federal centralization and the need to decentralize in order to ensure a tailor-made or fine-tuned care to respond to diversity and heterogeneity in the territory. Now, what you suggest in your presentation is that actually the centralized model, in the case of smallpox, worked better, because the dictatorship was able to take up the reins and centralize and take autonomy away from the local agents, and this contributed to the effectiveness of the program. And we know that the universal health system in Brazil is being attacked, and is currently being attacked because of its supposed inefficiencies. And part of the reason is that people say is that because of all of these localized and because of the difficulties in implementing things on the ground, we need to further dismantle the Brazilian health system and open the way for privatization. So I think there's just something interesting here. I don't know if you've gone very far in reflecting about this, about the implications of decentralization versus decentralization debate. And at a time, and this is why it's important for Brazilian democracy, at a time when the current government is returning to the celebration of the dictatorship and of the military coup, these kinds of arguments, if not taken into the historical perspective that you've given, can be actually a bit dangerous, right? And I'm sure you're aware of that. So I was wondering whether, I don't know if you've gone very far in reflecting, but I think there's potentially, if you haven't done so, there's potentially something very interesting here that you can make a fantastic contribution to debates about public health in Brazil and to debates about the future of Brazilian democracy. So well done. I think it's a fascinating research.
So right. Well, the 1965 campaign is actually very interesting. I only recently discovered it because a colleague of mine in Nepal had read the autobiography of the sort of originator of the project and translated it. One day I had this email saying, I think you'll be interested in this. And this, because I had kept hearing about this project, but there are no records. But so I had these translated few pages, and it illustrates a lot about the context and environment in Nepal at the time. And I sort of mentioned the very limited sort of health infrastructure that related to that. The pilot was seen very much as this is what was happening in the Kathmandu Valley, the main area. That didn't stop other areas through the health department if they wanted, or more importantly, if they were able to initiate their own vaccination. So any smallpox vaccination was the responsibility of the district sort of health officer if they had one. This area happened to have also its own independent branch of the Medical Association, and how it really sort of started was that essentially this doctor decided, well, if the world, other countries can eradicate smallpox, why can't we? And so set up a scheme for, started planning and meeting with people to organise this scheme for the children of their district. And the total population was about the same, so I think something in the region of 400,000. So this was not a small scheme. It's the same sort of population as the pilot project area. And so they started making links. But what was important about this was coming from within the community. So he and other personnel were working with the local authorities. They sorted out issues about payment, about training, things that were being raised as problems with the pilot, but this group, they were working out how to do it. They got the relevant people on board to support them. But as I say, the key feature was, and what the Zero field visit report picks up on, used people that were trusted within the community. So used teachers, people like that, people who had some education. And we need to think at this point, Lou talked about levels of illiteracy in China. In Nepal, it's even higher. So we're talking about maybe 4 or 5% literacy. So what they tried to do was to get people like teachers who had at least some schooling, but we need to forget about people with high-level training. But these were people who were trusted. And this was why it offered a way forward, because the later program did build on this need for having people who were trusted in the community, who were well accepted. Because if you think about the environment of Nepal, which sort of 97% is rural, this vast area, as I was saying, without the communication, without roads, without things, you were never going to get these teams going out. You had to work with the community setups that you'd actually got. You had to build up a group of people within the community. They didn't have to be health workers, health professionals, but the only way that they were going to achieve eradication and things was by, in this case, effective it's not just decentralisation from the top saying that you're going to have to set it up. You had, the actual implementation had to be decentralised. So you could still have in the end, what became your programme in Kathmandu. But the only way it worked in all the different areas and how it was gradually expanded was where you had got these local structures, local support. So this district where this campaign was started was one of the early areas for where it was expanded into, because it was seen that there was sort of support for it. But very much, Nepal, it has to be, if it's going to be implemented successfully, it has to be bottom up. And the question throughout looking at the campaign is, I keep asking, I say something like, oh, this is the first nationwide campaign. It was the first. Still the most astounding thing is, how on earth was that successful? it still amazes me that at the time that they did manage to eradicate smallpox because the challenges were so enormous. And it was certainly only could be done with support of people. And I haven't talked about anything about people's differing beliefs or acceptance of vaccination. There wasn't time to sort of do anything about that, but you had to have this this widespread throughout the country, people that could actually implement vaccination. So as I say, it didn't have to be health workers and different things. It had to be that widespread support for the programme.
Carlos?
Yes. John, you touched a very important point. I learned with Sanjay Bhattacharya that we must analyze history with historical concepts, not with our contemporary mentality. So in the 50s and the 60s, Brazil didn't have a strong basic health system. The services lack human resources, lack financial resources. So at that time, this way to implement public health intervention, the verticalized way, the verticalized approach, was the only approach that would work. So the centralized method was worth. But the situation is completely different nowadays. Brazil passed through, in the last decades, through a process that the basic health service was strengthened, and that was enable SUS to work in a decentralized way. The circumstances now are completely different, and I believe that this all this discussion about verticalized and horizontal approach, actually nowadays it lost a little bit of the sense, because actually if you strengthen your whole basic health system, you can accomplish even the highest priorities through public health interventions as eradicating a disease, as long as all your system is autonomous, homogenic, and you can provide the service through an integrated perspective to all your population. So you don't need anymore a strong centralized program, a strong centralized process. And we must be aware of that and be very careful to don't use historical events to justify our new different approaches with nowadays different situation. I think that was the former American President Barack Obama that said that we are entitled to our own opinion, but we are not entitled to our own facts. So the fact now is that the Brazilian system is strengthened. Of course, it's not an ideal system. It must be even further strengthened, but it's different than in the 50s and the 60s, that actually a strong centralized command was needed to accomplish the goal. So yeah, your comment was useful to understand that we must analyze different historical moments with different perspectives.
Can I just make one comment, because it's really quite interesting, because Nepal, need to emphasise, didn't have a health system throughout the country. So it was achieved despite not having the health system, which is why it's within the region. The idea was that you weren't going to eradicate it if you didn't have basic health services. I need to emphasise Nepal didn't have basic health services. So most people, there was no health service to access and things. So I sort of just want to emphasise that point.
Other comments, questions? Sir?
Good afternoon, Andy North. I just wonder whether eradicating smallpox is a double-edged sword. Now, that might seem a bit ridiculous, but what we vaccinate for now, measles, mumps, rubella, pertussis, diphtheria, TB, hepatitis, pneumococcus, and whatever else we do, they're all terrible diseases. But if you're a relatively intelligent parent in North America and you're being influenced by the anti-vaccines, if you do a risk-benefit analysis, the chances of your kid getting one of these horrible diseases is relatively small. Now, if you showed them a picture of what happens if you get smallpox while they're having their vaccinations, they're going to take the vaccinations because it's a beastly disease. And if you say if they get it, you've got a 1 in 5 chance of your child dying, they're going to have the vaccinations. Now, I was born in 1957, the year that Salk and Sabin brought the polio vaccine out. And everybody in my town went to get the polio vaccine because we all knew kids who walked around in leg irons or went in iron lungs, and we didn't want that. And the problem nowadays is the disease we're vaccinated against, although they have terrible complications, there's no doubt about that, are not quite at that devastating level. I just wonder how we're going to get over that.
Who would like to answer?
Okay, I would say that this question that you're raising right now, it was raised during in 1958 when the program was at discussion at the WHO. The problem is that if you take out vaccination from a society, disease will strike. And obviously the society will be aware of that and people will die. But if you introduce vaccine in a society, the disease will be forgotten. And actually the opposite will start to happen because a few people, you need to think the perspective here that needs to be broad, and few people would start to present side effects of the vaccine. And that will be the most important news in the press, that the vaccine is doing harm. But I truly believe that that's a role for the public health officials to educate the society and the population that if we take out vaccination and the disease strike, the harm will be even worse. So there needs to be a balance. And in 1958, the discussions with the developed countries was exactly that they support smallpox eradication because in their country was starting to become hard to convince the society that they need to vaccinate because side effects, the few people that got side effects from vaccines, they were started to be, their voices were louder than those few people that still got the disease. So I think that it's a question to be open to the society, honest to the society, to put the balance in the table, to justify that the vaccination is extremely important in a society level. And we can see what has happened with measles in 2018, 2017, a huge outbreak. Maybe it's time to understand that a major outbreak, it's a good point to start to talk about eradication of disease that is completely preventable. Because if we do that, we control the outbreak, people will start to complain about the obligation of a vaccine that might have few side effects. So it's a matter of to show to the society, as I said, seek political commitment, political support, because eventually we will control the disease again and the vaccine side effect will start to be highlighted opposed to the effects of the disease itself. So it needs to be negotiated with society, specifically with political leaders, and understand the specific points when to start an eradication program. So health education, I think, is the key, not only to the society, but to our political leaders also.
Yes, you go, Namrata.
I think this is also linked to this whole concept of herd immunity. I mean, the whole idea behind vaccinating 80% of people was that even if a few are left off, the 80% who are vaccinated sort of prevent any kind of disease from turning into an epidemic. Am I right?
Yeah, it depends on the disease, but in the case of smallpox, what was accepted as 80% of the population, we must bear in mind that when you say about 80 or 90% of the population, 95% of the population, we can't do the calculation on the number of vaccination in a population. We must to achieve 95% in the case of measles, for example, in all the population. We must not left small pockets of people unvaccinated because they will be susceptible to the disease and the virus will continue to circulate. So eradication programs and vaccination is another example, as John told, about universal health coverage. It's important to cover the whole society and don't leave pockets of people susceptible to diseases and infections.
I want to talk that actually part of that, we actually need to look at the reasons, and I want to go back to the time of the smallpox campaign and looking at why people did or didn't accept vaccination, because from the pilot project, there are one or two, there are comments that it's a lot, we need to be thinking from the level of people and thinking upwards, not just the health professionals down. People didn't vaccinate. As I say, I didn't get to talk about, say, belief in the goddess Sitala, and some people were against, but that didn't necessarily mean you couldn't vaccinate. But there were, people had questions, they had side effects from previous variolation. Vaccinators came, they did at the time when people were out at work in the fields. There's lots of practical issues and things that it became that those implementing the projects needed to listen to people and work at what was sort of going on. So really getting down to the local level. It's more than just going out and saying, you need to do this or you should do that. Even when they knew about, and as I say, smallpox was a common childhood illness, but they had varying attitudes towards vaccination. So it's a lot more complex than that, and I think we really need to sort of get back to focusing on what went on in that period. I've done a number of interviews with people who I call the grandmothers, people who had children who died of smallpox or got smallpox, or they themselves had smallpox. So their stories are quite different, and I think it's really important that when we look at the eradication campaign, and we need to look at what that wider picture. It's a lot more complicated, and there's some heartrending stories, obviously, in there.
I think this. Okay, very quick final. No, you go ahead because he's a member of our SNDT.
I could talk to him.
Yeah, but because we are running out of time and the gentlemen have to go home. But please, very quick.
Oh, thank you. I was just curious about, because in a way you've all been talking about the silences in the history of, and I'm just interested in sort of thoughts about why these silences. In a way, I thought it would be interesting, if this was a book, it would be interesting to have a chapter on the local story of the WHO. And, who was this Henderson? And, these characters, and where did they get, why was he so anxious about India not wanting help? And as you said, Nepal was a global story too. This idea about what's global and what's local.
And in fact, yeah.
Yeah. And so, I was just wondering, was it something about the institutional culture? Was there a sort of political economy, or was there something about these individuals and their backgrounds? I don't know whether they were sons and daughters of colonial officers. I just wonder what the story is also about, the WHO, and how do we begin to understand? We need to, in a way, sort of sort of reveal what these silences have hidden, but also understand why these silences happen. Yeah.
I think very quickly, if you want to respond.
That's partly what I'm trying to do, because I started on smallpox in Nepal because I read about this epidemic in the Everest region, and it just wasn't anywhere. And even the official count talks about 1958, not 1963, as the epidemic. And yet this epidemic, it does appear there's some numbers in internationals at the WER, but it's just for Kathmandu. The Everest area doesn't, but there's newspaper reports because of the climbing expeditions reporting that. So it's, so I think it's a fascinating sort of topic, and it's one of the things that I wonder, why, for example, in this epidemic, Is there nothing? You know, it doesn't appear into the records. And the other X1, the Lamjung, sort of the two volunteers were really surprised. It didn't even get into the Peace Corps' own sort of history. They're really put out sort of about that acknowledgement. So we have all these gaps and things. So I'm trying in because it's a small program and things, I can actually go down to the level of the individual, which is what I want to try and increasingly explore. But I think it's a fascinating area.
I think let's continue these discussions after the event. Thank you very much for attending. Thank you very much for presenting. I think it's been a fascinating set of discussions which provide us with much food for thought. Thank you very much.